Hi there, everybody. Wanted to talk to you guys a little bit about doing fine needle aspirates or cystocentesis, kind of the same procedure on both, just depending what we're really aiming for. So, if you guys are doing a lot of cystocentesis, I would highly recommend doing it ultrasound guided. For one thing, you get more information out of that quick ultrasound guided, and it's going to be a heck of a lot safer. Let's say you're just working up strained urea case or something too, or polyuria, you want to get a sample, maybe have some hematuria. Well, while you're getting that sample, even as you're acquiring it, you've already ruled out if there's any bladder stones or not. As you remember, if you're taking rads, you always have the possibility of having some of those cystine or urate stones that are not going to be radiographically visible, but you will be able to see them nice and easily on ultrasound. So I think it's a great tool to use to really utilize as much as you can. So when you're doing this, it's quick, it's easy, it's safe. I think everybody should become familiar with doing this, but I'm going to go through a couple tips and things too while we're doing this, just to make it as safe as possible and make it as easy as possible as well. So just thinking about fine needle aspirates in general, if you're already doing an ultrasound, you're seeing some abnormalities, probably liver and the spleen are going to be the most common sites that you'll aspirate, or if you're just finding some fluid accumulation and you want to get a sample of that fluid, also a great reason for abdominocentesis. I do like to aseptically kind of prep the sites. I'll clip it, use some Chlorhex, use some alcohol. I do the 3 and 3 kind of technique for that. I like to use, depending what I'm aspirating and the size of the animal, I've kind of gone to a little bit more smaller gauge needles than I used to do. I used to always do a 22. Now I kind of might do a 23 to 25, depending on what sample I'm getting. So we can do that. When we're doing that, typically use a 6 cc syringe. If I'm doing a big, large fluid pocket, it's going to be a lot of fluid, and I'm going to need a 3-way stopcock or something. Then I'll use, of course, a larger syringe. But most of my aspirates or cystocentesis, I'll probably use a 6 ml syringe when I'm doing that. I like to use my dominant hand to actually hold the needle. I feel like kind of hold it like a dart when I'm going in there. Where did I put my needle down? Sorry, I've got my needle in front of me. Let's grab one right here. So I actually like to hold it like an actual dart, like I'm throwing a little dart or something too. So I'll hold it this way. I feel like that can give me the most control. And then once I'm in, I can get my aspirates done that way. Then I'm going to be actually ultrasounding with my non-dominant hand. When you're looking at fine needle aspirates and stuff too, the hard part is they're definitely not going to be comparable to actually getting histopath on these areas. So we kind of have to think about which type of samples are going to give us the highest yield. Like I said before, most of the time it's going to be liver and spleen. And depending on what type of cell type we're expecting, if it's going to exfoliate or not. So definitely lymphoma, mast cell disease, those typically give us a good cytologic diagnosis. If we're thinking it looks more like a hemangiosarc, unfortunately, I think just with all that hemodilution, it's really hard to get a diagnosis of a hemangiosarc on there. If we're looking at spleen, maybe that metastatic disease, we can get a lot of good aspirates that way. Extramedullary hematopoiesis, we can get some answers that way. Liver, again, lymphoma, mast cell, vacuolar hepatopathies, we can get that on our cytologic diagnosis pretty well. A lot of our actual liver neoplasias, hepatocellular carcinomas and stuff too, sometimes they don't exfoliate as well, so maybe better off doing a histopath on those and not the aspirate, but maybe you get lucky. A couple studies look at the kind of accuracy of doing these cytologic diagnoses versus histopath. A lot of them, I think dogs for liver was like 51% or 30% histopath diagnosis. That it matched in like 30% of dogs, 51% of cats, where the cytologic diagnostics actually matched the histopath diagnosis on the liver. Looking at the spleen, we had a little higher matching correlation, maybe even up to about 60% in dogs and cats with our cytologic versus histopath diagnosis. So we can kind of do it that way. I like using either an inch or inch and a half needle, depending on the size of the patient that I'm going for and how deep my lesion is going to be. I typically like my curvilinear for most of the things that I'm going to aspirate on. It gives me a really good view. I think the angle is a little bit easier when we're actually going into the abdomen. Sometimes I will use a linear probe though, especially for really superficial areas, or maybe I just don't get a good image of it well with the curvilinear and I need that higher frequency of the linear, then I'll use that way. You just got to think about what angle you're going in might be a little bit different on the curvilinear versus the linear probes. Most of the time I'm going to do, we call it like a fine needle aspirate, but I actually don't typically aspirate. I kind of call it like the pin cushion technique. So you think about an aspirate, you would be going in and aspirating back on your nodule or something too. I typically will go into my lesion, especially doing a liver or spleen, maybe go about a centimeter or so deep into it and out a couple times, get a couple different tracks, making it that way. I'm calling that like the pin cushion technique. I just think we get a little less hemodilution, so we don't get as much blood contamination from it that way. I would do an aspirate technique sometimes if it's a really small volume of fluid and I need to just get directly in there and pull back, or maybe it's a cystic lesion that's not going to get a good sample that way and I want that fluid base in there, or if it's like right next to a big vessel that I don't want to hit, then maybe I'm going to go one single track in there, pull back and try to get my sample that way. So kind of two different ways you can do it, but I like to typically most of the time the pin cushion approach for it that way. When I'm going to kind of think about this for a second and talk about it, and then I'll practice. I've got a fun little jello mold here that I made to kind of show what we're doing. But again, thinking about what we're doing. When I'm dominating, I'm kind of using my non-dominant hand when I'm going in. And when you look at the probe itself, I always think about ultrasound waves. People kind of like to think in 3D, but ultrasound really is 2D. I'm sending images on a single plane coming out of this probe, right? So I think of that plane almost like a flat piece of paper coming out. So that flat image is what you actually see on the ultrasound screen, on your little monitor right there. So when I am putting my needle into this, I need to think about keeping my needle in the same plane of my images. So if I'm going in, I want it to be directly in the plane, and then I'll be able to see the entire length of the needle, seeing the tip of the needle, making sure I'm not going into anything I'm not supposed to. And that will keep it as safe as possible. I see a lot of people find a lesion and then they barely even look at the screen and they're not looking at the tip of the needle. And that's when we get in trouble. We may be hitting something. You may be staring at what you want to see on the screen. But if I'm not watching the introduction of my needle and seeing that tip of the needle the entire way, I might be poking into something that I don't want to. So I always want to keep in the same area, and you want to see the entire length of the needle, because if you think about it, if I was crooked, maybe I didn't go directly with the plane right here, and maybe I'm just a little crooked this way. Well, you'll see it for a split second as it penetrates that plane and then goes on the other side. Well, I'll see it just in that one little dot where it's actually within the plane of the ultrasound images coming through. So you'll see something and you move it back and forth and you feel like you see something moving. But if I don't see the whole length of there, and especially the tip of my needle, I don't know exactly where the end is. And I may be hitting a vessel. I may be hitting something I don't want to. So if we get good technique and doing it the right way every time, then we know we're safe. We know we're getting the right lesion. We know what we send off and spend a lot of money on cytology is actually the lesion that I'm hoping to get a sample of. So if you're just kind of going in there and you miss it, well, then I'm going to get a diagnosis on the piece of tissue that I don't really want. So I always do that. I always making sure I have the bevel up. I feel like a little bit of air in the bevel as you go into the abdomen. It's going to be more hyperechoic due to that air artifact. So you're going to see the tip of the needle a little bit better because it catches that little air a little bit in there. So we got that to kind of use to our benefit as well. All right, so when I'm talking about this plane, going through the probe, sticking it the entire way, pull my pressure back. If I'm doing my percussion technique, I'm going in, going out, going in, going out. I do not have any pressure on my needle as I'm coming out. Pull my needle straight out, and then I can actually get it on my slides and get my good sample that way that I can submit out to the lab. All right, so part 2 of this, I'll show you actually on my demo mold that I made, and we'll kind of go over this technique a little bit more. Thank you.